Hello, I'm Haejung Kim from Samsung Medical Center. It is my great pleasure to introduce our pictorial essay published in the Korean Journal of Radiology titled Nonmass Lesions on Breast Ultrasound, Radiologic-Pathologic Correlation and a Practical Guide to Diagnostic Approach. Most breast lesions detected on ultrasound are classified as masses. According to Virus, a mass is a three-dimensional space-occupying lesion that can be observed on two planes and distinguished from normal structures. However, with the advances in ultrasound technology, we now detect lesions that do not meet this definition. These are called non-mass lesions. Non-mass lesions are areas of altered architecture on ultrasound that do not meet the definition of a mass. They are analog to non-mass enhancement on MRI or asymmetry on mammography. Although non-mass lesions are not yet included in the fifth edition of Virus, they are expected to be incorporated in the upcoming sixth edition of Virus, reflecting their increasing clinical relevance. Our pictorial essay has three main objectives. First, to summarize U.S. findings of non-mass lesions. Second, to provide radiologic-pathologic correlations and illustrate representative examples across benign, benign with upgrade potential, and malignant non-mass lesions. And finally, to propose a practical guide that supports accurate diagnosis and clinical management. On ultrasound, non-mass lesions can be described using three descriptors: echogenicity, distribution, and associated features. First, echogenicity. Non-mass lesions are compared with subcutaneous fat and may appear hypoechoic, isoechoic, hyperechoic, or mixed echoic. Second, distribution. Non-mass lesions are classified as focal, linear, segmental, or regional. Focal means a small area less than 1 quadrant. Linear follows a ductal course. Segmental is triangular toward the nipple. And regional involves a large area over 1 quadrant. This classification is similar to non-mass enhancement on MRI or classifications on mammography. Finally, associate features. Non-mass lesions may show calcifications, abnormal duct changes, posterior shadowing, or architecture distortion. We can also see small cysts less than 1 centimeter and increased vascularity on Doppler images. These features help us assess the likelihood of malignancy. In this study, we classified non-mass lesions into three groups: benign, benign with upgrade potential, and malignant. Using this framework, we correlated imaging features with pathology findings and presented representative cases for each category. This case represents a typical benign non-mass lesion due to fibrocystic change, the most common benign breast condition. On mammography, there was an asymmetry, and ultrasound showed a corresponding hypoechoic non-mass lesion with focal distribution and interspersed small cyst without vascularity. Pathologically, these small cysts correspond to dilated axini within the terminal duct lobular unit consistent with fibrocystic change. This case highlights that multiple small cysts reflecting clustered microcystin pathology can serve as a reassuring feature of benignity. This is a benign non-mass lesion due to stromal fibrosis. Mammography showed architecture distortion, and ultrasound revealed an isoechoic non-mass lesion with focal distribution, architecture distortion, and increased vascularity. Stromal fibrosis represents fibrous proliferation that compresses ducts and lobules, creating a localized fibrotic area. These changes can mimic malignancy and sometimes with shadowing or distortion. Biopsy confirmed stromal fibrosis with histology showing collagen bundles intermixed with normal glands. Let me show an example of a benign lesion with upgrade potential. This case is an intraductal papilloma. On ultrasound, we observed a mixed echoic lesion with segmental distribution associated with small cyst and increased vascularity. MRI demonstrated a corresponding segmental Nonmass enhancement. Pathologically, papillary lesions are characterized by a fibrovascular stalk surrounded by epithelial proliferation. This fibrovascular core explains why these lesions often show hypervascularity on ultrasound. In addition, their intraductal growth pattern may produce segmental or linear Nonmass lesions accompanied by cysts or abnormal duct changes. DCIS can often present as a Nonmass lesion. It is commonly identified on mammography as suspicious calcifications or on MRI as Nonmass enhancement, and usually detected on ultrasound as a corresponding lesion during targeted evaluation rather than screening. In this case, mammography revealed segmental fine linear calcifications. On ultrasound, we observed a corresponding mixed echoic Nonmass lesion with segmental distribution associated with multiple echogenic calcifications within dilated ducts and posterior shadowing. Color Doppler demonstrated increased vascularity, and MRI showed a corresponding Nonmass enhancement with segmental distribution. US guided vacuum assist biopsy confirmed DCIS, and histopathology revealed high-grade DCIS with intraductal calcifications, a desmoplastic reaction that explains the posterior shadowing, and ductal dilatation that corresponds to the US features. Invasive lobular carcinoma is the second most common histologic type of breast cancer, accounting for about 10 to 15% of invasive cases. It is composed of small uniform tumor cells with a single file growth pattern and tends to spread diffusely with minimal desmoplastic response. Because of this infiltrative growth pattern, ILC often presents as a Nonmass lesion on ultrasound, frequently associated with architecture distortion or posterior shadowing. Associate fibrosclerotic reaction likely explain these imaging findings. Let me introduce our SAIHST approach for evaluating Nonmass lesion on ultrasound. First, confirm that the finding is true Nonmass lesion by checking both orthogonal planes and excluding normal variance. Second, correlate with other imaging. If suspicious findings are present, biopsy is recommended. Third, evaluate distribution. Linear or segmental Nonmass lesions are usually BIRAS 4 or 5. For focal or regional Nonmass lesions, management depends on associated features. Suspicious findings like calcifications, posterior shadowing, or duct changes warrant biopsy, while interspersed small cysts suggest benignity. For screening detected Nonmass lesions without suspicious features, BIRAS 3 with short-term follow-up is reasonable. This stepwise approach helps reduce unnecessary biopsies while ensuring detection of clinically significant cancers. To summarize, Nonmass lesions are discrete areas of altered echotexture lacking the three-dimensionality of a mass. They can be described by echogenicity, distribution, and associated features. Suspicious features such as calcifications, abnormal duct changes, posterior shadowing, or correlation with other suspicious imaging increase malignancy risk. Multiple small cysts suggest benign condition like fibrocystic change. A structured, feature-based stepwise approach can improve diagnostic confidence and guide clinical management. Thank you for your attention.